Central Standard, Oklahoma. I hope you're doing okay with the weather over there. I know that the barrel is barreling down on Texas, and it's hot over here too for sure. Yeah. Well, stay cool. Texas, San Antonio, Francisco, you're near Michelle, Coach Michelle. All right, well, let me hit record so we have a record of this. And we'll go ahead and get started. So welcome in to the 3-day EKG challenge, where we are going to spend the next 3 nights together getting you guys really confident with the basics of EKG. So I'm just going to hop onto Facebook. Some of you join on Facebook as well, so I can see the comments. And we're really, really excited to bring you tonight mostly the foundations of EKGs. And this is where it all starts, the magic, right? Where we lay down the foundation so that you have a better understanding. Now, speaking of understanding, I want to have an understanding of where you're coming from on EKGs. So drop something in the chat for me on how you feel about EKGs. Are you a beginner? Do you hate them? Do you feel like moderately comfortable with them? Like, give me some sense of where you are so I know how to best slate this to you. So are you a, 2 on a 10? Like, what level of comfort do you have with the EKG? Because we know if you're here, you want to learn something. Hate them. I feel like it's the one thing that trips me up. I've been comfortable with most for the last 4. Okay. Sort of okay, but need practice. Uncomfortable. Hate them. Okay. That's all perfectly reasonable. Second guess myself. You're not the only one. KJ says, I don't know anything. Not true. Yeah, no, I know. People second guess themselves all the time. So that's where we're going to bring it back to the basics and then build on that tomorrow with the arrhythmias. And then on night 3, Wednesday, we'll be doing the basic 12 lead. So Mary says, fairly comfortable. It's the rhythms that we don't always see. Okay, well, Mary, I'll include one for you tomorrow. That'll be just specially for you. And if you don't use it, you lose it. Absolutely. All right. Well, good. Then we're all on the same page. Okay. So let's kick it off. Now, the 3 nights I kind of covered, but we'll be spending some time together tomorrow doing rhythms. And then I said on night 3 doing the basic 12 leads. So tonight is going to be using basically the waves, the intervals, and also a little bit of terminology. And I'm going to share with you what I think is my secret roadmap to learning 12 leads. And yeah, as Andrea said, things change often. And that's true too. Remind me on night 3 to talk about that, because I don't want to do it now in this section. I want to save it for basic 12 lead, but I have a lot to tell you about some of the changes that you guys all need to know about. And we can cover some of them so that you can be safer providers. But really big changes came down in 2022 about things we need to know no matter what practice we work in. So going back, as I was putting together this class originally, I thought to myself, how would I have liked to learn EKGs instead of the way I learned them? Because just to kind of go back in time, circa 1995, I was in paramedic school and seriously contemplating my life's choices at that time because I was so bad at EKGs. And I just thought to myself, okay, I'm a smart girl. Like, I got good grades. Like, I can do this. What is wrong with me? Right? Like, I think we've all had one of those moments at some point in our life about EKGs. And then I just realized that I think I just learned it in a way that wasn't good for me. So I had that orange Dubin's book, and Dubin starts with like axis and vectors, which was way over at that time my head. And I felt like, oh my gosh, I was trying to understand just like the flat piece of paper relating to the 3D heart at that time. So like all of that was just so confusing for me. So I wanted to give up. And I don't know if you've ever had that feeling where you've also kind of just wanted to give up, but it was my love for medicine and my wanting to save lives that like pushed me through. And I had to find a way to get around this EKG business so that I could do the thing I wanted to do. It was like, you just know you're born to do something. I was like, that's me. Okay, so I was like, what am I going to do? So I ended up getting a tutor and just getting scrappy, like doing what I had to do because you have to learn this to get through it. So when I look back, I think, wow, if somebody would have shown this to me and kind of been there for me. I didn't have to hire a tutor. If I could have just, had someone I could lean on a little bit and a human to ask questions to, on like an everyday basis if I needed it, if I just had something to support, basically, right? Like someone to be the wind beneath my wings, that would have been great. But anyway, that's kind of what this challenge was like, okay, I am going to teach anybody for free who wants to come and learn. I'm going to teach the basics the way I wish I would have had it. And so that's why we're going to start with kind of the waves and some fundamental things so that you understand what we're even talking about. When we then tomorrow go to the arrhythmias and we'll talk about that. And I also will share some really easy ways to remember them and concepts that make sense. Like you're not going to just memorize, we're going to show you how to understand the arrhythmias because once you understand, you don't have to brush up because you already like, oh, this is how I solve the arrhythmia. This is the formula. And you just understand what's happening beneath the surface, right? And then I would want to know what a normal EKG looks like, and then what the 12 leads look at, and then the anatomy and how they fit together. And then I would want to jump into the high risk patterns, STEMI, subtle STEMI, mimics, and then eventually become confident. But here along the road, okay, over here, so, and here, this is where there's new stuff. Actually, I would honestly say right here, new stuff that they're now saying is new STEMI equivalents. And they're almost shifting away. And this rocked my world because like I just got comfortable, not just, but like, you know, I got comfortable with STEMI and like all of your criteria, just a lot. And then now you're adding on this other stuff, this, it's N STEMI, all the stuff that is N STEMI, which is like occlusion MI, which I'm not even going to blow your mind with, but we're shifting to the ways that the heart can tell us there's blocked arteries that are not STEMI. There's a lot of ways. In particularly, a lot of ways the LAD, the biggest, most important artery, can tell us that there's something wrong with it being blocked. So we need to know those, but we can't do that until we get the foundations down. So that's where we're going to start over here. And even if you're a 4 out of 10, you're probably going to get something from tonight because I'm going to share with you a couple rules for the waves, etc. Okay. So let's keep, and then so basically we're going to do a little bit of this. And if you want to learn more of this with my guidance, I am going to tell you more about our program that starts next week. It's called the 30-day EKG challenge. This is where we kind of take you the rest of the way if you need help and support through this. But let's get back to the basics and who's in the group and how many people there are that are varied here. So we have people from EMS, and honestly, I was EMS. I married a paramedic. Like one of my best friends was a paramedic. We were paramedics together. So I'm still a paramedic in my heart. I always will be. And I really think that what you're going to get from this is a little bit higher level of education than maybe you got. And then nurses, right? Nurses so many times a day save providers and patients, right? So you do, nurses a lot of times will say, oh, I don't need to know that high level stuff. Yes, you do, because a lot of times it's been a nurse or an EKG tech or medic that has caught something that a doctor hasn't. So I do believe, yes, you do need to know it. And nurse practitioners, PAs, right? We obviously need to use it. And then if you're a student, we're super happy you're here. We even have some MDs. We're happy you're here as well. So let's just take a peek in the chat. We have an NP in Tennessee. Matt is here. What's up, Matt? Blake Charles, you're a stress tech. Okay, cool. I didn't know that, Amanda, that you were a stress tech. And Anne says, I need all the support I can get. Awesome. And an RN, see, paramedic student, Melanie. All right, this is great. We love having students. PAS, Stephanie, I have chills, yay. And then Matt is a nurse educator. So Matt, okay, Matt actually teaches for our program, and he's here because He loves to support you guys. He teaches in our 30-day EKG program some basic stuff. So yes, absolutely, we are, right? Nurses do need to know. And that's why I'm glad we have some nurses here. So rock on, RN in Texas. Perfect, Casey. Thank you, or Cassie. Thank you for letting me know who you are. And then I also want to talk to you about a scholarship opportunity. Yes, he is an awesome teacher. So a scholarship opportunity, just to plant the seed, okay? So we give away scholarship to our program that we teach you the rest of the things every time we open up this challenge. Day one, I tell people the criteria, and it's not changing this time. I decided to keep it the same. And the criteria is this is a memorial scholarship in honor of my dad. And he was the most giving person. He was the one that would lift you up. He was the one that would cheer you on. And so this scholarship is given in his name. And so, what am I looking for? Okay, it's so easy to win this. You just have to be like my dad. I'm looking for someone who's going to support other colleagues that are in this, right? If you see someone guessing, like, good job, Amanda, good job on your guess, like, way to be brave, way to be bold, because that is exactly what I hoped to create with this group is other people who would not just me lift you up, but let's lift each other up. Because if you're here and you're putting in the reps, we want you to succeed. Okay. So it works better if we all do it together, not just me. And you're going to see KJ is going to be there too, lifting you up. And I always appreciate you, KJ and Matt, for being here every time. But I also want to see it from you other people who are here tonight, right? I want to see that. And whoever does the most of that in the most authentic way is going to win a scholarship. Now, what does that mean? You're going to get to be in for a month with us in our 30-day EKG challenge, absorbing all of the things. Okay, getting to go to all the classes. And it's really an experience. So you definitely want to win this. And I'll tell you more about it on night 3. So, yes. Okay, agreed. We need to work together. And right here, you're already getting my heart. Okay. He was wonderful. Yeah, he was amazing. So he raised me right and to give back to the community, which is what we're doing. But this, speaking of young, okay, look how young I am here. I think I was like 19. I don't know. That was my EMT partner, Frank. And this was one of my first, well, not my first. It was like, I was probably a year out of school. And here I am, right? I'm the medic. He's the EMT. So I'm a higher level than him, but he's the one that looks more confident, right? And I was like terrified. And it was at this station. This is why I bring this picture. Okay. It was at this station that I literally I sat down one night because I realized the gravity of like, oh my gosh, I need to know that if the EKG has something wrong. Because we didn't have cell phones back then. Okay. We didn't have like transmissions. It's like me or nothing. And that scared the daylights out of me. So I went into this cabana right here. There's a door. I went in and I sat down with a paper and pen and I was like, okay, I better figure out what can kill people that the machine's going to miss because there's like this pocket of things. And then I needed to memorize those things. So that's what I did. I didn't sleep all night. And that list is the same one that I used in my class in the 30-day to go through and make sure that people are solid because really you don't want EKGs keeping you up at night. But this is a long time ago, admittedly so. Um, Rocking the jumpsuit, I know, right? But flash forward to being terrified, okay, and really not feeling comfortable for a long time. And I think back to how vulnerable I felt. And what's interesting, okay, what's interesting is then here's me, okay, 17 years as a PA, 13 years as a paramedic. Okay, that's a long time. And here I am lecturing on national stages, working in the emergency room for 16 of the 17, no longer anymore, working outpatient cardiology. But now I transitioned jobs and I'm doing inpatient cardiology. And I feel sometimes like a drowning rat. Okay. So Crystal says EKGs have terrorized me. I know it, you're not alone. And so literally, okay, that was me in the jumpsuit, feeling like you, Crystal, then feeling confident, but now that I'm in a new job, it's a whole nother level. And I feel like a drowning rat sometimes. So I'm sort of back in your boat with you, rowing your boat with you. Like I'm coming to you from a place of like, I know what it feels like to ride the struggle bus. Let's just do it together. And there's no shame in that because you know what? You're here to get the skills. You're not sitting home watching a TikTok video. So just by that, you should be totally just 100% um, patting yourself on the back for that. And I'm agreeing with you. It makes you a better provider to be afraid because it means you care, but it also means you're going to be careful. And that's what's excellent. Okay. So again, this is just, we talked about the roadmap. We're going to do what is an EKG? What can it tell you? The normal waves, the anatomy, electricity. We're going to do rhythms tomorrow, 12 leads, talking about some more terminology, what normal is. So we're actually going to cover like a lot of these things through our 3-day, okay? So you're in for a treat. But this is the case that I want to bring to you first before we really get started. I'm currently driving the bus with a preceptor that is chewing me up. Oh, well, come here for your support and encouragement then. That is what we are for. Okay, we will lift you up. All right, so this is an EKG that this is a post-cardiac arrest EKG. And this is an EKG that you could see any day. This patient luckily survived, okay, neurologically intact because he had good CPR by a family member. But is there anything on this EKG that could have predicted? And I'm just taking your temperature right now. I'm jumping in the deep end because I want to see where you are for real. You've all told me I'm a 4 out of 10. I'm really comfortable or I'm not, right? But this is the EKG that you can use to kind of like really set your bar, right? Nav deep. Yes, I love it. Okay, T-wave inversions. Cassie, yes. Um, I love it already. You guys are in the chat, making me totally just chills. Okay, so Crystal says peak T's. All right, so tell me what lead you're looking at. Are you looking at V2? Because up here we saw T-wave inversions from Cassie. Let's talk about Cassie's T-wave inversions because yes, you're right. These are inverted. And not only are they inverted, they're symmetric and there's a meaning to that. Okay. We worry about the more serious things when they're symmetric. And then, yeah, as KJ said, the inversions with AVR. So yes, AVR's T-wave and V1's T-wave, they should be inverted and they're not. So good job. The multiple leads always intimidates me. Caitlin, I know, but I'm going to share with you something really quick on that note. And thank you for telling me that so I can be really clear. If you go over here, let me grab my pen. Okay. This is right here. That's our 12 lead. Okay. All these leads are our 12 and they're just looking at different parts of the heart. This here down here is our rhythm strip. Okay. So this is the one, this is just lead 2, hold out down here. And this is the one, the best one to start looking at the rhythms. Okay. And so if you go over here, just to use this as an example, this is a P, QRS, and a T. Okay. So what I like to think about is they're like a family. Okay. So the P is the mom, the QRS is the dad, and the T is the baby. They all should be holding hands together along the EKG. And we should also be looking at, are the R's, are they all coming at the same time? Is this a regular R to R? And it is. Okay, that's what we want to see. We also see the P wave, right? It's nice and not, bumpy or lumpy. It's not too tall, not too small, not too close to the QRS. And that is all very important. So this indeed was actually, you may have already guessed it, this was a normal sinus rhythm, okay? Now, if this is a normal sinus rhythm, does it mean it's a normal EKG? And it's absolutely not, okay? And there's some other stuff going on. And you can see that, there's other symmetric inverted T waves. And we'll talk more about this later, but I'm going to point out something to you, or unless somebody wants to guess, somebody other than KJ, because I know you know the answer, KJ. But does anybody else know how to describe this T wave? Does anybody know how you would describe it? Oh, yes, Melanie, there is definitely ischemia here. Absolutely. Okay, definitely. But does anybody know? And it's okay if you don't, because I'm going to teach you something if you don't know this before we jump into more terminology. But this is called, why are the T waves? It is an anterior lead. Yes, Amanda, absolutely. Peaked P, inverted T. So the T wave, there is a problem. Totally agree with you. And now, so this one right here, it actually goes up and down in the same wave. And that is called biphasic. Okay. And biphasic means that they're, oh, good. Yes, Stephanie got it. Um, Oh, tombstones. Tombstones are actually what you'll see in the ST segment in the that'll look like a tombstone, but this is just it's biphasic. It goes up and down. It like can't make up its mind. And it does mean that there's ischemia. So whoever said that, good job. Stephanie, it is called biphasic. So just understand there's a basic fundamental rule, okay? Rule number one, the T, it should be all the way up or all the way down. No wishy-washy T waves, okay? Like the one in V3. We also have another rule, and that rule is all T's must be upright except for AVR and V1. Well, guess what? Yes, right? There's a lot of problems here because you already correctly identified. You said, hey, this is upright. This is upright. That's not supposed to be. And all these guys are inverted all over the place. So basically, okay, there's a lot of problems on the EKG. So of course, and this one being the worst right here, of course this guy was going to have cardiac arrest. There's signs of ischemia all over his EKG. So this guy is literally why I bring this up in the very beginning, because it's the subtle things that eventually will matter. But we can't find them unless we go back to the basics first. So it's important to understand that we need to always know who's running the heart, and the EKG is basically sending, well, it's capturing signals that the heart is sending to the paper and transcribing those signals. And it allows us to tell who's not only running the heart, but also how big the chambers are. It tells us, about other clues, electrolytes like hyperkalemia, hypocalcemia, things like that. There's all sorts of little things and messages if we just know how to learn how to interpret them. So this is a 12 lead, and I put this in here because this these are, I forgot, these are called minions, and this is what I picture is like inside the software, like telling us this little spit out printout right here, because it's wrong anywhere from 6 to 42% of the time. So we can't be wrong that much. So if you also thought when you first started this, okay, computers are smart, I'm going to go and just like listen to what the computer says and I'll be fine. You can't always do that. In this case, the machine is right. This is actually a STEMI. Okay. So it's a STEMI and it's telling you where it is, antero in the front of the heart, which is right here. V2 and V3 feed the front of the heart, because we're seeing ST elevation. We're seeing enough to meet criteria. When that's a whole nother thing we'll talk about on night 3. But just understanding that the computers are actually probably programmed by the plaintiff's attorney, right? They don't want you to get anything correct. It's literally true that there's this phrase that it can write. You tell me if you've seen this before, where the machine says non-specific ST segment changes. Non-specific ST segment changes. Okay. Or it'll say some variation of that. Has anybody seen that? Yeah, Crystal's seen it so many times. It's really true that a lot of people will go, oh, okay, well, I'm just gonna, non-specific, I'm gonna refer to cardiology. But no, I gotta tell you guys that literally that's not the right answer. The right answer is that you gotta look for the 5 dangerous things. that it could be. And it usually is not benign. I've maybe seen it be actually benign, like non-specific benign. Maybe, I don't know, I could count on one hand. So you really, it just means the machine doesn't know what it is and you need to go sort it out. I've seen it call a STEMI non-specific. So it just means that we really need to not rely on the machine software. And that's really what it comes down to. So we got to understand too that we are basically interpreting, right? So we're interpreting for the heart using the EKG. So that's us, we're the interpreters, and the heart's trying to talk to us through the EKG. And you could almost say it's sending us Morse code almost, and we need to interpret Morse code. And honestly, it is another language. It really is. We just need to know the terms. So before we do that, what we can do is go back to the foundations and understand how to be a translator by understanding who's underneath, what those signals can tell us. So, for example, if you think about the heart is very much like a house, and pretty much anybody can sort of relate to this house thing where you've got plumbing, which is the vessels, you've got the electricity, which is conduction, you've got the walls, which are the muscles, and the doors, which are the valves. So literally, we can tell, if you think about it, blocked arteries with an EKG. We can tell the conduction, who's running the heart with an EKG. We talk about the P wave there. Is the P wave present? Is the sinus node running the heart? The walls, the R wave, the size of it can tell us how big or small that the actual walls are. And then the doors, if they're stiff or they don't open or don't close well, a lot of times they'll cause the chambers to be enlarged. And that's something we can see. So there's so much more information just waiting on the EKG that we can actually tell. And kind of going back to concepts for a second, we're looking at to see how big this wall is by the size of the R wave. So if it's really big, there's a lot of tissue there. If it's really small, there's a potential that it could be it's really that there's something in the way, like a pericardial effusion, but it also could be the heart's not beating very strong, like a low EF, low ejection fraction, or even I don't know if anybody's heard about amyloidosis lately, and I feel like the only reason we're learning about it now is because there's a drug to treat it. Um, Seems to happen that way, right? So, but amyloidosis can also cause low voltage. I don't know if any of you used to watch that show House, but I swear, like every other episode, his diagnosis was sarcoidosis or amyloidosis, right? Do you guys remember that? And now, like, amyloidosis is being talked about all the time. It's a real thing, and it's actually quite common. So anyway, it's funny if you watch that show. So this is an example of what low voltage looks like. And you can see, right? If you use the mom, dad, baby analogy, the mom, dad, and baby should not be the same size. Okay, these R waves are very small. This is someone that I would be worried about them having a pericardial effusion, the fluid blocking the electricity getting up to be scanned by the EKG. Okay, and that's not normal. You want to have more variation in size, okay? So, and then the opposite would be if the R waves were really big, you would worry about this ventricle being really big. So that's going to be read by the machine. If you have really big R waves, it'll say LV strain, okay? It'll say that all the time, LV strain. That means that it's seeing signs of a big ventricle with, big R waves, and it'll also see an inverted T wave that'll look like a check mark. Okay, so that's kind of that. So, but getting back to conduction, let's talk about the conduction, because going into the heart, this little guy here, what is he called? He's called the what node? So we've got that node, that, and we've got to talk about these guys. Okay, yeah, exactly. Okay, so this here is the SA node. And this here, AV node, as you guys perfectly mentioned, good job. And then down here, these guys are the bundle. Branches. Try talking and typing. It's really hard. Okay, right? Bundle branches. And yeah, these guys actually, Crystal's taken it one step further and she's like, hey, these are her Kinji fibers, which are these little smaller guys. And you're so right. That's them right here. And yes, then there's the internodal pathways also to the AV node right here. Goodness gracious, you guys are so smart. So there's a lot, okay? There's a lot. Now, basically, a wave is neither negative or positive deflection from the baseline. Okay, so the baseline would be the most isoelectric line, the flattest line. So this wave right here in AVL would be positive, right? And so that's kind of how we talk about the direction, and this is the conduction. So not too hard. And then let's talk about these waves, what their names are, going back to very basics. Yeah, I know, very smart group, KJ. So let's shout it out when you know it, or type it in the chat. We're going to see how many fast typers we have. What wave is this one? P wave. Good job, Crystal. Everybody who's typing P. What about this one? Stephanie, good job being number one. Q wave. Good. What about this one? This one is called the R. Good, Anne. And then this one is called the S wave. Yes, good job. And then this one here is called the T. Oh, KJ is usually the fastest typer. KJ is always the one to beat, you guys. And then last but not least, it looks like Amanda already is all over it. This is a U wave. Shouldn't be there. Only the PQRST should be there. Good. Okay, looks like you guys are pretty solid on that. So remember, we did have the P, right? And we know that it needs to come before the QRS and that it's not supposed to be pointed. It's not supposed to be too big, not be it's too small or inverted. The QRS shouldn't be too tall or too small. The T wave should be upright and not pointy, and then the U wave shouldn't be there. Okay. And I don't know if you were ever really taught this, but it actually, no one ever taught me this. I just figured it out on my own that the T wave is actually not supposed to be symmetric. And so, like, this one right here is a good example. I actually drew this. Surprised it came out this good, but it was asymmetric. They shouldn't be symmetric ever, whether they're upright or inverted. They shouldn't be. And as KJ pointed out, there's a terminology thing that's important to understand here. So if the T wave is the baby, then when we talk about the T waves, when they're upside down, they're not depressed. Okay, like KJ said, only ST segments can be depressed because babies can't be depressed. T waves can be pointy, they can be big, inverted, biphasic. What else can they be? They can be normal, right? So just understand there's lots of terms to throw around, but we're never going to call, if they're upside down, we're never going to call them depressed. Mom and dad can have lots of issues, but not the baby. Exactly. That's a good way to say it, KJ. So this P wave here, right? Look at how nice and beautiful and perfect it is. Not too tall, not too small. I don't know if you remember that poem. I think it was called Goldilocks or something, where like the girl breaks in to try the porridge, or was it the bears that were trying the porridge? I don't know. Someone's eating the porridge, and there's one that's like hot, too cold, and one that's just right, right? Goldilocks. Okay. But it's been a while, but I always remember that like that person was like so persnickety. They needed it just right. And so that's what the P wave, right? We're persnickety about our P waves. They need to be just right. Not too small, not too tall, not too pointy. We have so many like rules. We're like the Goldilocks of the P wave, right? But this one's great. And it means that the SA node is contracting the atrium. Yay. And then we've got the ventricles contracting over here. Q, tiny q, R, deep S, which is not normal. Going back up to the J point, which turns into the ST segment, which goes into the T wave. which in this computer generated drawing is a little bit too symmetric for my taste. So this would not be a Goldilocks T wave. So understanding also the width of things is important. So the QRS, right? QRS, it should be how wide? How many small boxes? So small boxes, what do you guys think? How many? Okay, good. Yes. And also it should be no more than 0.12 or 120 milliseconds. Good. 3 small boxes, Stephanie says. Absolutely. Great job. And so knowing that is important because when you start to get over 120, we start to think about bundle branch blocks. We think about hyper K. I'll finish that. We also can have other issues like, like tricyclic overdose, which would be very rare, or even, VTAC. So the width really does matter of the QRS. Okay. So, and wide or narrow, exactly, Melanie, exactly. The PR interval, okay, that one should be basically the time it takes from the impulse to go down from the SA node down into the AV node. And that is, we're always looking at that for time. So it should also be, notice the similarity, 120 milliseconds, just like the QRS. They're the same. If it's 120 to 200, it's normal. If it's under 120, we're thinking about Wolf Parkinson's White looking for a delta wave. And if it's over 200, we're thinking about a first degree block. And that's just measuring, okay? And so that would be 5 small boxes for the 200 milliseconds, okay? So that's kind of, in a nutshell, why we're looking at that PR interval, because the numbers matter. And then also talking about waves, there's the Q wave. And now you guys, I just showed you an example of a Q. This is technically a Q, but knowing the difference between a physiologic and a pathologic Q is really important. So pathologic, AKA bad, that is really where you have to measure. And if it's a third the height, like this one is, then it's bad. So you basically go from here to here and you cut it in thirds. And this is at least a third the height, therefore it is pathologic. And this one is wide. So deep or wide is pathologic. Now, there's a lot of other things that Q waves can mean. I don't have a whole lot of time to get into it tonight, but just know that what you've probably been taught about a Q wave is it means old MI. And that is usually true, but there are other times where a Q wave can be present and they can be bad. For example, pulmonary embolism. For example, hypertrophic obstructive cardiomyopathy. Both of those things are bad, right? They can kill you. So you have to know that the whole story about the Q is not just part of the story, right? That a Q wave can be more than just an MI. And what do they look like in the wild, so to speak? I grabbed a real EKG and I drew on it. I was like, I just want to show you. So the machine is going to, if you know there's a Q wave, the machine is going to say where it is, and it's going to say, so inferior, which is in 2, 3, and F, okay? It's going to say age undetermined. It says that because it knows that Q waves can come within the first hour of an infarction. So they're not always old. And this whole concept, right? It's actually a third or higher or greater. That's what this is. And the machine is programmed to know that. That's why it's pointing it out to you. So, yes. So less than a third can be a normal unless it's in V2 or V3. Any Q is not accepted in V2 and V3. And even if your Q wave is small, you have to make sure it's not part of a pattern like the S1Q3T3 or the hypertrophic obstructive cardiomyopathy. So in general, it's going to be benign if it follows. There's lots of rules with Qs, but I'm just trying to keep it super simple because we're in basic land of just sharing with you that this is the criteria that the computer is looking at to know if it is pathologic or not. And that's why it says age undetermined, because it doesn't want to be responsible for saying, oh, that's an old MI, right? No, no, no. That's not okay, because it doesn't know. And we may not know either, especially if we don't have an old EKG for comparison. So speaking of the T wave and it being important, I wanted to just throw in a couple of them I actually do more of them in the 30-day EKG challenge, but I brought a few of them out to parade for us, so to speak, so that we could basically like talk about them, because the T waves are really important. Well, good. We solved a mystery for you tonight, Mary. I really hope that you learn to love the T wave because I love the T wave. And maybe not because I love it, but because I want to share my infectious enthusiasm for the T. Free the T's, right? KJ said. But because there's so much info there, this is not even all of the T's. But let's just go through them. Okay, so this one right here, this guy, he's a little asymmetric. He's not too big, he's not too small, he's not inverted, right? So he's a normal one. Then here's this guy. Okay, he is looking pretty big, but he also has some ST elevation. Now, we couldn't tell you what this is. This could be three things. This could be benign early repolarization. It could be a STEMI. It could be pericarditis. We need a 12 lead to really tell what's going on. So I don't know. He's going to stay where he is for now in jail until we figure that out. But this guy, he can get out of jail. Bye-bye. And this guy right here, he has a reverse checkmark appearance to his ST segment. So this is what's going to be called LV strain, which just means there's a big ventricle, usually from untreated hypertension. Usually, not always. But what do we do with that? Nothing in the acute care setting. We're going to tell him manage your blood pressure better. But it's not ischemia. So he can get out of jail too, technically. Okay. Then there's this guy. How would you describe this T wave? What would you say? That T wave is very, what do you think? Yeah, good job. Caitlin, Mary, peaked. That's the exact word I was looking for. Depends on if we're treating extremely high BP. Yes, peaked, exactly. And the LV strain is an inverted T. It is, but it's asymmetric. That's why we're not putting it in jail. And then that's exactly what I was going for. So you picked up on that. Thank you. So concern for hyperkalemia, Crystal, I would totally agree. This is a hyper K, till proven otherwise. And so he's going to stay in jail. And then this is the opposite, basically. And this is a hypo K. Can hypo K be dangerous? Should he stay in jail? What do you guys think? Can hypo K be dangerous? Absolutely. Everybody says yes. Okay. So we'll keep him in jail, him in jail, him in jail. These two can go free on bail. And hopefully we won't see them back in jail again. Just kidding. Okay. Anyway, okay, speaking of T waves, oh my gosh, you guys, I love the EKG so much because literally almost every T wave is misbehaving. So look at this. First of all, remember the only two, yes, AVR and V1 are upright. The only two that can be inverted are these two. And they're not even following the rules. They're upright, which a lot of times means ischemia. A lot of times, not always. And this is one of the cases where it was not true. But everyone else should be upright. That guy's not following the rules. Neither is he. Neither is he. Nope, 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 nope. Okay? The LV strain looks like a hockey stick. Exactly, Matt. These are not LV strain. Okay? The only two people who are behaving is AVL and V2. These guys, they're upright. They're supposed to be. So yeah, they're good. But everyone else is bad. And so the key here is that this was a real EKG, by the way, real patient, okay? This patient had inverted symmetric T waves and they were diffuse, okay? So this patient was having palpitations, was an athlete, like very active athlete, and was having so many palpitations, she just couldn't keep going on her athletic run. And it turned out she was having runs of SVT, runs of VTAC. And the clue that something was wrong was in the T waves. And so one of the things, there's lots of things that an inverted symmetric T wave could mean, but one of them, which she had, was a cardiomyopathy. She had a really rare form, but cardiomyopathy can also cause these T waves to be inverted. It's one of the differentials, and that's what she had. So her cardiomyopathy was leading to all those weird arrhythmias that she was having. And the clue was in the EKG. Now, are you going to make that diagnosis on the EKG? No, you're not. You're going to get an echo. And of course, you're still going to think about ischemia, think about both, right? And do the complete workup. We found her ectopy on a Holter monitor. So the long and the short of it is that she ended up needing to be watched very carefully, needed a lot of medications, and it was not a good situation. So exactly, it's a piece of the picture, have to assess the symptoms. I love that, Melanie. Absolutely 100%. What she said. So yeah, lots of T-waves behaving badly. Another term that we got to do while we're in the waves and all that is the R to R, because we're going to use this tomorrow. We're going to be asking you, hey, what's the R to R? Is it regular or irregular? So tell me an example of a rhythm that would have an irregular R to R. Tell me an example. Aphid, that's exactly what I was thinking. Good job, ladies. Okay, so yes, and regular things, SPT, normal sinus, we'll talk about all that tomorrow. But this is what we're measuring. This is the R to R. So easy. Okay, now let's talk about the segments. These are also equally as important. You shout it out when you know it or type it. Okay, what segment is this right here? Mm-mm. Good, Mary, fastest typer, PR, good job. Okay, what about this one here? This one is and I'm not going in order, notice that, to QT, good job, Mary. I think KJ, you got some competition. You gotta get those fingers a little faster, KJ. Anyway, this segment right here, what's this called? ST, crystals, now in the running. I love it. Oh my gosh, KJ, are you even here? Where are you at? And then right here, this is the QRS, Cassie. Wow, you guys are rocking it. Seriously impressed. KJ's napping. Okay, no problem. But anyway, these segments are all important. So I want to stop and talk about I'll talk about the QT more, but the QT more is probably one of the most important, in addition to the ST segment, obviously. The QT is something that we can affect with drugs, and prolonging the QT can lead to a really bad rhythm. Does anybody know what it's called? Prolonged QT can lead to a lethal arrhythmia. Torsades, Cassie, good job. I love it. Good job. And good job, Mary. So, all right, this person, okay, I got to tell you another secret about the QT, okay? The machine is not always right. It's not always right when there's artifact. I'm calculating it, but otherwise it is pretty good. So I remember this day still. I was working at a hospital, and I had this EKG tech that was on my shift, ran this EKG over to me, and he was, because he knew, he's like, oh yeah, you're one of those geeks that likes EKGs. I'm like, yeah, yeah, pretty much. So he ran it over to me, and there was just me and him in the doctor's area. And he was like, look at that QTC, 713. The QT should not be over 460, basically. And this was 713. He's like, have you ever seen anything longer? I'm like, no. And he's like, are you so excited? And I was like, absolutely. So for a second, like we like danced a little bit and ate some potato chips to celebrate, like, just a festive thing, because like it's kind of like, you know, women don't have, football touchdowns, right? And I'm always jealous of that, because I want to have like something like a touchdown. Well, this is a touchdown, right? Like this is scoring the big fish, all the things. So I was so excited, and then I was like, oh no, hold on, wait a minute. We got to slow the roll down, because I don't think this is right. And he's like, what do you mean? I'm like, let me show you. So I go, look at this. We got to measure it. And so I said, look at this R and this R. And if you go halfway between and you measure half, well, actually, that's not even right. I did it wrong. So like that would be half. Okay, so relatively right in there. My pen isn't working so good. And so the T is right here. So you know that if it's halfway between, it's like at least 500 milliseconds. That's the rule. It wasn't yet that, so there's no way it would be 7:13. So anyway, yeah. Okay, I'm trying to keep up the worksheet and chat while following. Oh my gosh, you're so funny, Crystal. You can always rewatch this. These are recorded, so no worries. But this was basically not a prolonged QT. So the machine was wrong. He repeated it. It was normal. It was like 441 or 444. Here it is repeated. And you can see that, yeah, this is correct. So the artifact can mess it up. On that note, don't be shy to ask for another EKG if you have a lot of artifact, okay? Really important. You need to see the clear, true EKG. So super secret squirrel messages. So this is my dog Remy. He'll pop in probably on the challenge. I actually kicked him out tonight because I just wanted to make sure it was just us so I could focus. But he's telling us that these numbers matter, the numbers at the top, and they do. They really, really matter. And the QT is a great example of it. So I wanted to share this case with you. Oh yeah, he was just in here. You want to boop his nose? I know, he's so cute. I know. So we were at a shelter today looking at a dog to adopt for to be his bestie, but he didn't really vibe with that dog, so I'm really sad. It was really cute. His ears are full of wisdom, trust me. He knows how to solve all the STEMIs. STEMI with Remy. So this is a real case where the patient had some chronic neck pain. And yeah, he's tired from hunting STEMIs. And she had hypertension and some psych issues. So she was on a lot of psych medications. So her neck was really bothering her. And, her neck injury was she had a bunch of fusions from some boxes falling on her. So she was really uncomfortable. She also had some stress because honestly, who doesn't have stress these days, right? And she felt unwell, like the water ran out of her. She did, I know. She gave that hard a workout, I know. But it wasn't the pain just wasn't getting better with the two methadone that she took. If I was live, I would stamp in front of you, methadone. Okay, it's a hint. And she drank some alcohol, did some cocaine, and then didn't feel very good. So she called 911. 911 arrives and they find her and she's like kind of stumbling. Check for a carotid bruit. Um, You could always check for a carotid bruit. Um, Feeling like the water ran out of her, is that what you're thinking? Weird she didn't feel better after the cocaine. I know, I know. But anyway, so methadone will prolong the QT, exactly. And so they found her, she was sort of wobbling and she collapsed into cardiac arrest, into torsades, actually. And they ended up defibrillating her once and she got pulses back. This was her door time EKG. So now we got to solve the mystery. Why did she go into cardiac arrest? So, it's interesting because you said you love those cocaine-induced heart attacks. Those are really legit. Those are legit. And so it turns out we have to treat them differently than regular flavored garden variety MIs. Like beta blockers are contraindicated or relatively contraindicated. But basically, yeah, the QT is the key right here, right? So Matt says, look at the QT. Let's do that. So let's just go. I like going over here for some reason tonight. So R to R, halfway between. Look at that. We know the QT is going to be about 500. It actually was 512. And that is why this patient went into cardiac arrest. Oh no, your guy died. I'm so sorry, KJ. Um, it balances out the calories. I don't know about that. I don't know. I don't know. So anyway, this lady, she's on a bunch of QT prolonging medications, and also cocaine didn't help, but they get her off all her QT prolonging medications, and she was on 5 of them. And lo and behold, she comes in and has a normal QT finally. So she was told to not go on those medications again. She got an ICD, unfortunately, because she had sudden cardiac arrest and prolonged QT to prevent her from dying again. And as far as I know, she's still alive, thankfully. She's turned over a new leaf. So can you see the power in this? It looks like you guys are talking about beer. Oh my gosh, that sounds good right now. Find the zebra. Yes, so you can see I'm wearing a zebra hunter shirt. Find the zebra. There's always a zebra. So can you see the power in learning the foundations in a way that maybe you have a story behind something that makes it stick? instead of just rote memorization. So I want to know, what is the one thing you are most excited about learning tonight? And maybe it's that the cocaine and beer contraindicate themselves. Maybe that's it. Knowing normal to be able to see abnormal. I love that, KJ. And while you guys are typing in the chat what your favorite takeaway of the night is, know that tomorrow will not be as long. It will be a shorter class, and it will be arrhythmia practice and arrhythmias. But there's going to be a prize each night. Okay. So KJ said, I also learned not to mix alcohol, cocaine, and methadone. That's a good takeaway. I definitely agree. But we're going to have a prize each night. So I'm going to show you what the prize is for tonight. There'll be a different prize night two. And then there will be on night three, we'll be doing the scholarship giveaway. Oh my gosh. Don't even worry, Melanie. We're gonna have, and Caitlin, we're gonna have so much more fun. So keep coming back. It's really an awesome group that we have with you guys. You guys are very interactive, and no lie, this has really been a special night. Seriously. Good. Okay, Cassie, and more on the way. But let's talk about the prize, and then we'll end the night. Okay. So the prize. You ready? Tomorrow, 5 o'clock. Yep, 5 o'clock PST. The prize is the EKG workshop kit. So someone's gonna win this tonight. Are you guys excited? Do you guys want to know what's in it? Okay, so let me show you. So first of all, I painted this. This is a painting I made like a long time ago, and I put it onto this cardboard box. And it's become like the thing that goes with our 30-day EKG challenge. So like if you end up joining our 30-day, we send you one of these. Okay. But I'm going to pick one of you tonight to give this away to. So here we go. Let's see what's in it. Oh my gosh. Okay. So many good things. Okay. So first of all, crayons. And yes, they are black with cute colors because I just love the black. Like I bought a bunch of these when they came out. And they've got the three colors that we actually color the heart arteries with on our cheat sheet. So there's blue, red, and green. Okay. There is quite possibly one of my favorite things because I'm biased. Okay, but I have some news on this. It's going to be important. Okay, like KJ said, a painting. Okay, and everyone, I'm actually making some right now for the next joiners of our class, so they have paintings, and they go on a little easel. They're so cute, and these. So funny story. Yes, I'm an international artist now, you guys. My art's flying right now to the UK to hang in an exhibit for sudden cardiac arrest awareness, and it was displayed in San Francisco as well. So like my art is taking off. So you guys are all going to have individual pieces, which you could probably sell someday when I'm really big. Who knows? So I mean, I'm telling you, this is a good gift. Plus, it's cute, and you get to have it on your desk. Okay, but probably the best part of this is this. Oh my gosh. Have you ever seen these? This is so cool. I know, awareness through art, and I'll get to share the pieces that are going to be displayed as soon as they give me permission. I can share them. But I actually made one of the pieces. There's a hypertrophic obstructive cardiomyopathy patient that I'm friends with. She was never my patient, but I'm friends with her. And I put her in the art. Oh my God, it's so cool. I can't wait to share it with you because she's like a motivational speaker on picking up hokum. But anyway, okay. This is so cool. This is a tool, and it's got this red line here. And this actually helps you find ST elevation. So cool. This helps you right here look for heart rate. There's anatomy on the back. There's looking at, how wide a segment is here. These are like $14 on Amazon. These are like not free. Okay. Like all this stuff costs, but I'm going to give it away for free tonight. Now, you're also going to get this. You're going to get this. Okay. You're going to get this EKG workbook. It comes with real EKGs, like real ones, not fakey ones by the computer. And there's like other stuff. There's little exercises in here that we do. There's this one where this guy was a STEMI 5 minutes later. That's a really good one. You're going to get that. You're going to get my cheat sheet that has axis on it. And it also has like the 5 things you should look for. 5 things you should look for in a syncopy palpitations patient. Oh my gosh, I'm still grabbing things. And then There's also this normal EKG that you can use to practice and make your own cheat sheet with the crayons. We actually walk you through this if you join us in the 30-day in a workshop. And then there's this little like explanation of how to use your tool that you get in this. So I'm going to give this one, it's going to be this one. So it'll come with this painting, one person, but I'm not going to tell you who it is tonight. You're going to have to come back tomorrow to see who I pick as the winner. A way to get you to come back tomorrow because we want you to come play with us. We love playing with you guys. It's so fun. Okay. So now I'm done throwing everything around. Before we break for the night, do you guys have any questions about anything? Life, why is the sky blue? EKGs, questions. Okay, yes. Oh yeah, so we'll do the workbook. We'll do that. Yeah, your whole workshop. I know. I'm not doing that tonight because we're at an hour. We will start filling it out tomorrow. We'll start filling out tomorrow because we have more time tomorrow. Tonight I had to try and fit out all into 1 hour. So because some people are east like me and you guys have to go to bed to work. But your whole workbook is going to be filling up. We're going to be working on it tomorrow. So don't worry, Crystal. Got you. You have 1,000 people in your house. I don't remember the 3-day, but did we go over reciprocal leads? That is in the 30-day. Thank you so much. Do you have a link for the workbook? Yes, we do. It's in the group, actually. And if you go, Andrea, if you go to, unless Ruben's on, he can copy and paste it. But if not, if you go in the Facebook group, it's in the featured post up at the top. Or maybe KJ, you can maybe grab it and put it in if you see it. It's just, Haley, it's just a workbook that I provide with the course so that you can follow along. And then I put the answers in the, I put them in there as well in the top of the group. But let's see, who needed the workbook? Let me see if I can, while you're on here, grab it really quickly. Let me see. I'll go into our 3-day group. By the way, let me take you with me. Let me take you with me into the 3-day. So I think if I go here, you're going to be in our 3-day. All right. So this is, you could go here to this post and you could click right here for this, but I'm going to put it in our chat. This is where you can go. And I'll put it right here. So this will give you the workbook. It takes you to Facebook Messenger. And then just another little interesting thing about the group. If you go to events, you can do a couple things. You can put going and it'll remind you. You can put, you can go into the event right here like this. And you can even like see the Zoom, which is right here. And you can see who all else, wanted to come, and you can click this and add it to your calendar on any event that we have. That goes for the 30-day or the 3-day. Just know that. And then I think if you go into the guides, we're going to put tonight's recording in there. It'll be guide 1. We're going to take these out, move all these out, and just put our 1 in here. So it'll be not confusing. We'll have this in guide 1. And then we'll have your video there for you to rewatch, okay, under guide 1. And then let's see in files, what's in the files. Oh, here we go. There's actually, if you want to download it here, you can get it here as well. So there's lots of different ways to get it. You can just download it and then I'll show you what it looks like. And it looks like this. So we'll go over these, but really you could fill this in tonight if you wanted to for homework. We talked about almost all these things today, the first 2 pages, but we'll go over them tomorrow at the beginning. But just in case, this is the workbook and it goes all the way down to, we go through some arrhythmias, and then day 3, we're going to talk about the leads and what they look at. So that's kind of what's coming. Okay. Let me see what else I missed in the chat. So did you get that link? Hopefully you got the workbook. Does anybody have any other questions or any confusion about anything? Otherwise, I'll see you guys tomorrow. Yeah. All right, KJ and Matt, thanks for being my wing people. As always, you guys are amazing. Thank you, Ruben. And we'll see you guys tomorrow. Bye.